My name's Angela. I'm the director of nurses at the Mennonite Home, and I'm doing an in-service on fall prevention. Some of this relates to the Mennonite Home itself, but a lot of it's good information for everybody. That's why it's open for everyone. So I've been told I need to draw this out to a half hour, so I'm going to try and do my best, but usually I get nervous and talk really fast. So falls prevention, the objectives we have are to identify the impact of falls on residents and the organization, recall federal regulations for fall prevention, identify intrinsic and extrinsic factors for falls, recognize the role of the resident assessment in falls prevention, and identify strategies to prevent resident falls. So every year, 1 in 3 adults age 65 or older falls. Between 50 and 75% of nursing home residents fall every year. Many residents fall more than once. Falls in nursing homes occur at more than double the rate compared to other older Americans out in the public. A typical nursing home with 100 beds has 100 to 200 falls a year. Falls are the leading cause of injury among adults 65 or older, and the most serious injury from a fall is a hip fracture. 1 in 5 people who have a hip fracture will die within a year of the injury. Other complications include loss of confidence and mobility. Since they've already fallen once, now they're afraid to walk anymore, so they sit and won't get out of bed, or they won't get out of their chair, which causes their muscles to atrophy, and then they're at increased risk of falling again once they do get up. 1,800 nursing home residents die from falls every year. And this is current. I updated it, so it's not an old one. 10 to 20% of nursing home falls cause serious injuries, and 2 to 6% of nursing home falls cause fractures. So the risk to the facility from a fall is the injury treatment costs. Obviously, if we are determined to be a part of the cause, then we have to pay the fees for the hospital and such. We also have insurance claims. We can get lawsuits, and then the state or the federal government can fine us money caused from the results of a fall. Medicaid, Medicare require facilities to maintain an environment as free from accident hazards as possible, and to provide adequate supervision and assistance devices to prevent accidents. The Joint Commission National Patient Safety Goal is to reduce the risk of falls by assessing the residents' risk for falls, implementing interventions to reduce falls based on their assessed risk, evaluating the effectiveness of all falls reduction activities, and providing education to staff, residents, and as needed to their family. So falls, there's a couple different definitions for a fall. We need to have the definitions to be consistent so that not one place calls a fall one thing and another place calls a fall another thing. So we want to have clear guidelines of what a fall is so that we all know what happened. So a fall is a sudden unintentional change in position that causes an individual to land at a lower level. They can land on the floor, on an object like the bed, or on the ground. And this does not count falls where maybe someone gave them a shove and knocked them down. So a good example is someone is getting up from the toilet and their hands slip on the rail and they sling themselves back down on the toilet. That is considered a fall because they had an unintentional change in balance position. A fall with harm is any injury caused by falling, and a near fall is a sudden loss of balance that does not result in a fall or other injury. This can include a person who slips, stumbles, or trips, but is able to regain control prior to falling. So if I'm walking in the hall and my foot trips on my other foot, but I grab the handrail and am able to keep myself from falling, that is still considered a near fall, because had the handrail not been there, I most likely would have fallen. In the Mennonite home, we had 215 falls from June 1st to June 1st. One of our highest incidents has been falling from bed onto a fall mat. Now, some of our beds to the fall mat is only 3 inches, but that's still a loss in balance, so it's still considered a fall. We have purchased new beds that can expand wider, so they can go wider and longer too, and that seems to have helped decrease our fall rate. So for the year, June 1st to June 1st, we had 5 falls with major injury. And obviously our goal is to decrease the number of falls. So why do people fall? There are multiple factors that create a risk for falling. Intrinsic factors are related to their physical, mental, and cognitive condition, which I like to remember it by thinking internal risk. And the extrinsic factors I think of as external, and they're related to the environment. So does anyone have any idea what could be an intrinsic factor, an internal factor that could cause a fall? Loss of sight. Medications. Let's see what some of them are. There's a whole bunch. Then one of the big ones is your age over 65. If you've had a history of falls. If you're incontinent. So why do you think being incontinent could help lead to a fall? In a hurry, trying to go. Lower extremity weakness, gait and balance deficits. Maybe they're not as steady as they used to be. Medicines can be tranquilizers, sedatives, or antihypertensive drugs. So the sedatives, obviously, and tranquilizers would make you sleepy, but the antihypertensives could maybe lower your blood pressure too low so that you aren't steady and you get dizzy. The use of 4 or more drugs at one time can lead to a fall risk. And then there's other things, the hypotension, the eye acuity decreased, loss of hearing, perception changes. You know, the floor maybe seems to be going in an elevation when it's not really. And then disorders of the spine, functional impairments. They can't perform the daily activities they used to be able to, which when they're trying to put their pants on, maybe they tumble over. Change in mental status. Dementia is a big one. Sundowning, foot problems. If you got a foot drop, your foot's not going to stay flat as much as for the good balance. And then belief that asking for help is inappropriate. And we see that a lot with the older people. They don't want to ask for help. Think they can just do it on their own and not bother anyone. So what maybe are some extrinsic factors? Cluttered room. Yes, loose rugs. Shoes. Here's some examples. Poorly designed bathrooms that don't have handrails or raised toilets. Tables, beds, and chairs that are on wheels. Floor that is highly polished, wet, or covered with loose carpeting or rugs. So the highly polished floor can actually cause a reflection from the light, which could help someone to trip. Their shoes don't fit, and their assistive devices aren't maintained. Maybe they've got a loose wheel on their walker, or their support pole is not sturdy, and maybe they haven't been taught how to use their walker or their wheelchair. And then the time of day also can be an extrinsic factor. So, and I've noticed this in the Mennonite home, and probably it happens at Quail Run too, at shift changes and increased time of falls. And then the bed too high, the toilet too low, the full-length bed rails, which I don't think anybody uses those anymore. Noises, miscommunication between staff and family and the resident, poor staff training, and then this is a big one, being attached to equipment such as an oxygen concentrator can trip on that tubing really easy. So the results of of what a fall happens afterwards is we have to figure out what caused that fall and try to prevent future falls. So, and this is across campus, not just the Mennonite home. After every fall, an occurrence is started, and then there's different ways that we go and evaluate it. In the Mennonite home, the resident care managers, myself, and the nursing home administrator all review the occurrence, and then we have investigations into why it happened, and then interventions are put in place to help prevent further falls. So what can we do to protect falls? So a thorough resident assessment, an environmental assessment, a medication review and eliminate medications that can cause falls, frequent rounding to address their needs, for example, toileting, and do they have access to personal items, proper use of technology to reduce falls risk, exercise and balance training, identifying residents who have special needs, and effective education of residents and family members. So an assessment is performed upon admission. This is a fall assessment. And when a resident's physical or mental condition changes, when a fall or a near fall occurs, yearly and as required by state regulation. We have an electronic form that's completed in the AOD on admission and quarterly to assess for fall risk. Resident rooms should be evaluated and modified to meet the resident's needs. Keep beds in the lowest position if the care plan says to, or keep it in whatever position the care plan says to. Some people have it in a higher position for their safety. Have the residents wear well-fitting, appropriate shoes. Ensure clothing will not cause tripping. I think a lot of people wear baggy pants anymore. Maintain a quick response time for cleaning up spills. Cordon off wet floors and construction areas. Use caution signs that are understandable to all visitors. Leave dry areas around wet floors when possible. And appropriately time the mopping and or vacuuming of high volume areas. So I know in the Mennonite home, in the dining room, the big one, they close the doors when they're mopping and don't open them until the floor's dry. So that's one way that can help prevent someone going in and slipping. You want to make sure that all your furniture wells are locked, tables and chairs. That doesn't mean lock the wheelchairs when someone's in it though, because that would be a restraint. You want to perform regular preventive maintenance on our organization-owned mobility aids, canes, walkers, wheelchairs, lifts, and our maintenance department does that. Assist the residents to obtain preventative maintenance on their own mobility aids, which I think our maintenance people do that too. And then remove furniture with sharp corners. You'll see in some rooms that we have a foam thing that can go on the edges. And ensure grab bars and wall rails are properly mounted. Keep floors uncluttered and remove low objects that could cause a resident to trip. Ensure that rugs do not have bulges. Ensure that steps are clearly identified. Minimize distracting noises and guard against icy walkways, construction, and uneven surfaces. So we have this good catch thing that we fill out. So if you see like you're walking on the sidewalk and you see it's higher, you can put in a good catch for that and maintenance will go out and level it. Administration of medicines that can increase falling, antiarrhythmics, antihypertensives, diuretics. Why do you think a diuretic would increase falls? Because they have to go to the bathroom. Laxatives, the same thing. And there's a bunch of other ones. Psychotropic sedatives. So the risk is greatly magnified if the resident has 4 or more types of medicine. So frequent rounding to assist with resident needs is one way we can help prevent falls. So during the visit to a resident's room, offer them toileting assistance, ask about their pain and if they need pain medicine, reposition them if they're in bed or a wheelchair, and ensure all their necessary items are within reach. Call light, phone, water, tissues, their remote control. That's a big one. Restraints, we do not use restraints, but they can lead to falls. So proper use of technology to reduce falls, use high-low beds, have nurse call systems, and ambulation and transfer aids. So the new call system that we have is the same that Quail Run has, the Tectone iAlert thing. So we can actually call to a resident's room and ask what they need. So that's a big bonus that will help us in the future. And then exercise and balance training is a good way to prevent falls. A sustained program involving strength, balance, and flexibility can improve older adults' physical function. Working with life enrichers to maintain strength. And we do have several classes a week in which all residents are invited to attend. And this class is in our activity room, and it doesn't have to be long-term. It can be short-stay people too, and it's a really good exercise class. And then we also can use short-term physical therapy as needed. Residents with dementia are at greater risk of falling than those without an impairment. Failure to communicate a resident's risk of falling is one of the causal factors of falls-related sentinel events. So a sentinel event is like a fracture or a head injury. And falls are more likely to occur when staff have not been apprised of a resident's risk of falling. So it's important that you check your care plan. The care plan would identify anyone who is a fall risk and have interventions for you to do to help prevent falls. And don't be afraid to report a fall. It's through investigation that we're able to try and prevent future falls. So whenever we know of a fall, investigating it helps us to be aware of what that resident might be at risk for in the future. To educate residents, we want to talk to them face-to-face about fall risks in a way that they can understand, explain the general risk factors. This could happen on a new person, a new admission too. Explain their specific risk factors, like if they have a broken arm, you can tell them, you know, you're at risk for falling because if you trip to the left, you won't be able to grab the rail to stop yourself. And then discuss different strategies to address their risks. We can teach the resident how to use the call light, assistive devices, walkers, etc., how to transfer in and out of bed, how to avoid falling, for example, call for assistance, or if they are falling, how to fall if it's unavoidable, how to have a safe fall. Lean against the wall to slide yourself down. And then if they fall, we want to make sure they know not to move until somebody comes to help them. We want to educate family members, manage their expectations for safety, explain the resident is at risk for falling, express our concern for their safety, and explain the need to have the resident maintain as high a level of functioning as possible. Like, we don't want to confine someone to bed just because they're a fall risk. And then we want to provide education on the use and maintenance of assistive devices and document all discussions. So CNA could have this discussion and document it in their charting, and like a laundry person could let their supervisor know that they had a discussion. If a resident falls, any staff member who finds a fallen resident should remain with and verbally reassure the resident and call for help. We always want to ask the resident, what were you doing just before you fell? This is a really important question because it helps us to know maybe they fell because they were going to answer the phone that wasn't by the bed. Well, then we know we need to keep the phone closer to the bed all the time. An assessment must be made to determine if there was any injury, so never assist a resident off the floor without a nurse present. The licensed nurse will always do an assessment and notify the physician and the family or the responsible party. Documentations for reporting a fall include the date, time, and location, the description of the fall, names of any witnesses that saw the fall, notification of the family and physician, description of any injuries, what treatment was provided, the intrinsic and extrinsic factors, staffing levels, equipment that was in use, medications taken before and at the time of the fall, and any new intervention plan. The care plan will be adjusted accordingly after a fall if we need to change it. And then the occurrence report will be filed in RL, and the resident is placed on 72-hour monitoring. So when you come upon a fall and you're doing an assessment, whether you're a dining member or a CNA or a nurse assistant or a resident assistant, it's important to look at the environment. Whenever you see someone who's fallen, look around and see, is there anything knocked over or is there anything they could have tripped on? And you would ask them what they were doing. So that, like I said before, that's one of the most important things to find out is what they were doing before they fell. And no matter who finds someone down, you can still look around and ask the question and let the nurse know. So we do have a falls team at the Mennonite home, and we meet weekly. It is the resident care managers and others as needed. And we review every fall and help to find individualized interventions for the residents. At times we may invite others to brainstorm with us, such as housekeeping, dining, social services, or CNAs. And here are members of our fall team. And just to summarize again, age 65 plus, 1 in 3 people fall every year. Age 72 plus fall every 2 years, and age 80 plus fall every year. So I would like to open up for questions, but we need to have REL bring a microphone around if anyone has a question, because when we're watching these back, we can't hear what the questions were. So does anybody have a question? I got 7 minutes to kill.
Okay, in-home care, if you find out about a fall, even though it may have happened 3 days ago and nobody was there, do we still report these falls as?
I'm just going to repeat what you said so they can get the beginning. If you're in in-home care and you find out about a fall, even though it might have happened 3 days prior when nobody was there to see the fall, should you still report it? And I would say yes, because otherwise there could be 7 or 8 falls that nobody knew about when something could have been done to help prevent them a week ago. That was a good question.
And those can be reported to NEL or to SUE?
Yes, you can report those to NEL or to SUE. Do you need any help with your test?
I have a question. What's a good way to determine in-home care bed height?
A good way to determine bed height.
Oh, a good way to determine bed height.
What we do is we look at the person themselves. So am I more at risk of falling because I'm in a low bed that's so low to the ground that I can't get my legs underneath me and I'm gonna fall? Or should I have a higher bed so that when I slide out of bed, my legs are right where they should be at the ground, thigh height? So it's just individualized based on the person. Some people who aren't going to stand, obviously you don't want their bed up high because then they can't stand. If they roll off the bed, they're gonna fall. That's a good question though. And you could always ask your supervisor too. Anyone else?
My question too, I didn't quite get all of the input for that. On question number 2, I didn't get all the one sentence that they wanted.
What did you put?
I got a sudden unintentional change in position and
That's good. Yep. All right, well, thank you. This is my longest in-service I've ever had. Oh, wait, got one more still. Yeah.
Okay, can you hear me? I think most of you know me. I'm Paula, I'm a physical therapist here. I don't know what all Angela went over, so there may be a repetition, but that's not necessarily a bad thing, you know, when we're trying to get just the different ideas and safety stuff in our heads. I want to go over, in particular, safe transfers for transfer technique. But I'll say in general, in terms of fall prevention, it is all of us. It is every little detail, all these things that adds up. You know, whether we're looking at, are the person's brakes on their wheelchair holding? You know, are we checking that before we get somebody in or out of a chair? And if not, are we making sure we get somebody in there to fix it right away? Are we looking at their footwear? Sometimes our non-skid socks have been used so many times there is no non-skid on them. So are we looking at that? Are we getting the right footwear in? Are their shoes fitting right? Are they wearing slippers that they're sliding out of the back of and they're more hazard than they are safety? Is the floor wet? You know, has housekeeping just come in and cleaned and now we need to be aware of that safety risk? I mean, there's tons and tons and tons of little tiny details that make a huge world of difference in fall prevention, okay? So, transfers. When I go in, actually, I'll put this here. When I go in to help somebody transfer, the first thing I do is I think about, okay, what's my plan? What do I, you know, how do I want this to go? And what are all my nets? You know, what am I putting in place in case it doesn't go as I'm hoping it will? So that, so I'm not just stuck there. Okay, so you always have a plan B. You go in, is the room set up safe? Are the wheelchair leg rests out of the way? It's a huge tripping hazard to have the wheelchair leg rests there. So, you know, you can swing them out of the way to take them completely off and stick them away out of your own tripping hazard. So now they're out of their resident's tripping hazard and out of your tripping hazard both. Or if somebody has to rush in and help you, your plan B, right? Are they out of their way as well? So completely out of the way, not just off to the side. Is the bed in the right position? Is the chair angled to your bed correctly? You know, all these little things. Say, I'm going to have somebody get up, and I'm just going to help them up, and they're going to walk to the bathroom. What's my just in case? You know, is there a chair there that I can easily pull up to them if their knees buckle? All of those things. Okay. So, gait belts. Okay. Please use them. You will see therapists not using them, and we're doing that for a specific reason in their therapy and in their rehab. And it doesn't mean that it's okay not to use them in just general mobility. They need to be used. And they're a great safety tool, they really are. They're a great safety tool if they're used right. If you don't have them low and tight, they tend to just slide up and move around, and then they aren't much help to you, and they're really uncomfortable to the person, okay?
Yeah, I have residents say, oh, you're making it too tight.
Right, right.
And I say, well, the minute you stand up, it's going to be loose, and I don't have nothing to grab.
Yeah.
And I go, okay.
So I don't know if you guys could hear that. So she was saying people will complain that they're too tight. And she says, the minute you stand up, that's why I tell people, you stand up, you get skinny, right? And it's going to be tight. And it's, you know, get them out of the chair that much quicker, right? They're motivated to stand. I need a volunteer. Who will be my volunteer? I'll be nice, I promise. I won't drop you or anything. Come on, I know you're dying to. Such a sucker. Oh.
Every time. Every time.
Every time. The other thing I do with the gait belts is I tuck the end of them because I don't want this catching in the chair or around something and stopping us midstream. Okay. So if I'm going to help him up, I don't want to lift him. I don't want to get hurt, right? If I'm going to help him up, I want him in a position where he can do the most possible. If he's in this position and I'm standing here and I say, okay, Ryan, stand up.
No.
He can't do anything. I mean, you guys could try it right now. You stick your feet out there and you lean back and somebody's in front of you. You have nothing. You have no power. So now it's all on me, and I could hoist him up, hopefully not get injured, but we're both in a precarious situation if we do that. So I want him to scoop forward, and I would do that, but go ahead and scoop forward. And I want him in a position just as if he were going to stand on his own. He's going to be able to lean forward. That's the motion we naturally do. Go ahead and sit down again, okay? And if he only needs that much help, that's all I'm going to give him. I'm just going to be here and help him, and his walker's there or whatever. If he needs a lot of help and his legs are weak, I'm going to come down. He's still in that good position. I'm still going to put him as if he's doing it on his own. But I could come in, brace his knees, and I can move him. And if his knees buckle like that, I have him, okay? And so the next part of that, what do I do with him when I get him there, right? If I had his chair right next to his bed, say, so it's right along here, I've got quite a ways to go. If I angle it, about 30 degrees, I've actually got a shorter distance for his bottom to go than if it were parallel, okay? And I can have somebody right here helping me, right over the hump there, to have that extra person there helping me. If I get this hip really moved forward, scoot way forward on this side, and his foot turned, now he has a very short distance to go, and we can just go right over here like that. You know, and I moved him that far. His feet were already in position. We didn't get in that place where we've got our feet tangled up if he's not able to move them well. If I had him, this is what people want to do. They want to look towards where they're going. And that, now his bottom's farther away. If I did that and he couldn't move his feet, I get stuck. And we're just back down. Okay? Questions on that? Setup is everything. Setup's everything in terms of making it easier for you, making him more able to help, but making it safer. Clear your pathway and plan for the just in case, you know, the worst case scenario, so that you've got the safety set up.
Right now, although it varies, how did you didn't go straight in, right? Because that is awkward. You were to the side of that?
If he didn't need as much help, I could come in on the side here and just help here. And I like having a nice squat position. So I'm going to tell him to stand up, and I'm going to follow that motion. Go ahead and stand. And I follow that motion just with my weight shift and my legs. And then I can really guide him, you know, just with my body motion.
How many squats am I doing?
How many am I doing?
And then from the front, you were on one side rather than dead center, which is too awkward for
I like being a little bit to the side. I'll tell you just today, go ahead and sit in that seat for a second. Just today, I had somebody that really should be a Hoyer lift, but she came in, no sling in place, in a transport chair. We had to get her out of her chair. And so I scooted her forward a little bit, and then I got her feet here, and I rolled her up and went dead center. And then I could have her here like that. I don't do that very often, because that's when you need a Hoyer lift. We just couldn't do that right then.
Both knees to give you a little bit more leverage for someone. Or if somebody is like, okay, so what if he's walking, but he's walking poorly and he starts to go down? What do you do?
I got this.
You got this. So if he starts to really go down, I've got him pretty well here. I'm going to let him go. I've got the chairs in my way, but I'm going to bring him back on my body.
Like say they're walking along and then their legs start to get out.
Yeah.
And have a,
Yeah, go ahead, walk forward a little bit farther. Okay. I can drop him. I am not going to hold him up. The instinct is to do that, but that's not safe for you.
well, I do in-home care, so I don't unfortunately have a lot
Yeah.
of these options.
And so sometimes that happens, and that's what you do have to do. And it's nice if you can just pull them back to your body and let them slide down to the floor, because it's a pretty gentle landing. And what you do, you can pull them back to your body and step
Guide them
back.
back.
So, okay, worst case scenario, you don't have a gate belt on them and they're going to start falling. Like they're starting to collapse because it got really weird. Is there anything we can do? I mean, we obviously don't want to let them crash and break something, but
Yeah.
I mean, like,
It'd kind of be the same thing. So if he's going to stand up and there's no gate belt on him, if you're holding him in some way and he starts to fall, hopefully you can just take him in that way. Sliding down your body. And I'll tell you, I'll be the first to say, the reaction, you want to hold them up. I have tossed my body on the ground so that they landed on me, because I so did not want them to get hurt. That's not really the right thing to do. But if you can pull them, and it's nice to be on their weaker side, so that, because that's the side, if they have a weaker side, that's the side they'll tend to collapse on. And then, they're collapsing towards you, not away from you. If they go away from you, there's not really much you can do.
When we take and have the person scoot up a little bit, we'll verbally, do that, but also we count 1, 2, 3 up. I mean, slower than that, but I
Yeah.
mean, so they are walking back and forth about 3 times, and then
Yeah.
the third time they are.
And some people respond really well to that, and some people that it feels like too much, or, it's a great tool, because it gets them, as you said, in that, okay, I'm going to come up, there we go, and everybody's timing is together. Yeah. So I do that on some people. I don't necessarily do it. A lot of people give the cue of nose over toes, which is that idea of leaning forward. I don't always do that, because then they start doing this, and that causes another problem. I'll just tell them to lean forward, or I'll tell them, take your chest way out here. But also, the guidance